What about the field of physical therapy has surprised you the most since you started?
Man, that's a loaded question. First of all, thanks for having me on.
Of course.
I really appreciate it. But what has surprised me the most? The lack of progression.
Mm,
Hands down. I've been, um, I don't want to say surprised. I have been surprised to a certain degree, but
whoops.
maybe not as surprised as disappointed at the lack of progressiveness and the lack of full utilization of our scope of practice, and the reluctance of employers and the reluctance of therapists to really get going on that.
Yeah, I kind of see like this weird slowness of the field itself. It's kind of not really moving forward like we'd like to see, right?
Yeah, so I started my career in the military, and I think just viewing everything from that model, and then seeing how it is in the civilian sector, it's been interesting because it's not like I moved from kind of moving at a more of a I'm more of a technician. I only receive referrals, and then moving closer to something that's a little bit more autonomous. I started off autonomous and then have lost things along the way as I've progressed from the military to an academic setting, and then into the private sector. And the private sector is tough. It is stinking tough. And I think insurance companies are largely to blame for that. But yeah, yeah, that's all I have to say about that.
Yeah, it's weird. I guess for people that don't know, in the maybe you can describe it better than I can. In the military, there's a lot more autonomy with physical therapists, and I guess what was your experience with that?
Yeah, so to explain why that is, back in the 70s, of course, 60s and 70s, Vietnam was happening, and physicians and healthcare providers were pretty hard to come by. And there was a much higher volume of patients who had need versus providers that were able to provide care. So the military model started using physical therapists and other non-physician providers as physician extenders. And so physical therapists would see individuals with neuromusculoskeletal complaints, like your ankle pain, your neck pain, your, broken bones and things like that, as an initial first contact provider. And then it's kind of remained that model ever since. So in that role of a physician extender, the physical therapist is not only providing treatments and managing individuals with neuromusculoskeletal complaints, but they're also serving in a role of initially assessing and evaluating patients comprehensively and determining their need for other referrals and determining their need for imaging or related medications. So we really are serving in this more neuromusculoskeletal primary care role. And that model has stayed the same. And when I started in the Army, I was very quickly, maybe, 2 or 3 months in, positioned into a soldier-centered medical home where I was the PT in an integrated team of primary care providers, so physicians, PAs, NPs, and there was me as a PT. We also had behavioral health, and radiology right down the hall, and pharmacy right down the hall. So yeah, I started my career that way. And then I moved into the private sector where things really are still largely referral based. You can only see a physical therapist with a referral from your physician, or a physician will write a referral and ask for specific treatments. And then there's some sort of expectation that you will follow through with those. And I think that some people in the general public and some healthcare providers still think that we sort of function under that model exclusively, whereas we are very highly trained in differential diagnosis and yeah. So I've been surprised about that. That's the lack of progressiveness, and the lack of consistency between the military and the private sector.
Yeah, and we've made leaps and bounds, and we have direct access a little bit in most states, so that's great. And Was this experience, you saw the almost ideal in the scenario when you were in the military. And I guess, was this the first time you started to notice a problem with the current model in primary care?
No, I would say my initial thoughts about primary care started to emerge before I was even a PT. I remember being in college and sort of wondering about that, because I remember in my annual well check with my primary care physician, I remember him um, kind of I mentioned, I do have some knee pain when I run. And I remember him saying, oh, you'll probably just need a total knee replacement. I kid you not, this is what he said. You'll probably need a total knee replacement at some point down the line, but you should be okay right now. You're 19. And I was just like, what? Like, there's got to be a better answer than that.
Right.
And so my thought was, if now that I know what I know now, and looking back, if there was a neuromusculoskeletal expert on site in that primary care team and I was complaining of knee pain, I probably could have gone to that person and gotten more evidence-based and up-to-date answers.
Right.
But of course I'm biased.
Only a little bit, but that's okay.
Yeah.
And so I guess let's paint a picture for, for people in the space of physical therapy and also in healthcare. We have an idea of what the current model looks like. And I guess, is it everywhere where we have this current model of care where you need the referral in order for you to see a physical therapist? Or maybe, people are just getting the runaround with, they go to their primary, then they go to maybe see a chiro, or maybe they go to see an acupuncturist, they see a massage therapist, and then they finally come to see us. I guess maybe paint us a picture of like what the current model looks like for patients that usually go through, like if my ankle hurts.
I still think, to a large degree, most people in America, if they have an ankle complaint, for example, that they would probably go to their primary care doctor first. And depending on what their primary care physician or PA or NP says, or what their viewpoints are, or what their experiences have been, that they might try to manage it with anti-inflammatories, avoidance of activity initially. And for some new musculoskeletal complaints, that actually is very indicated, that self-management strategy is. But so they'll try that first. And then if they come back with the same complaint within a number of weeks, then they might refer them to physical therapy, or they might refer them to orthopedics. It really just depends on the experience and the education and training of that person making the referral. So I think that's typically what it comes down to. And I also have come across primary care providers that are somewhat reluctant to refer to anyone because of their experiences of patients being sucked into a rabbit hole. And that includes physical therapy.
Right.
So sometimes patients, will get, stuck in the wrong physical therapy clinic where, they want them to be, they really just kind of want to maximize their number of visits that their insurance allows. So then they see patients going to physical therapy and staying for like 16 visits when they might not need to. And then other people might refer to physical therapists that practice guideline concordant care and manage things in a more concordant way. And then maybe those primary care providers might be more likely to refer to PT or ortho or whatever, whatever the case may be.
Right.
So I think it really, really, really just depends on what the unique perspective and experiences of each individual primary care provider has been. But I think largely people with musculoskeletal complaints will go and see their primary care manager first. And if it's spine pain, I've also seen majority of general public recommend chiropractic care above anything else as an initial point of contact. That has been my experience just from family and friends that are not in the healthcare industry.
Yeah. And that's not to bash, of course, chiropractors. It's more of just, understanding that there's going to be good and bad providers out there. And I think that's the point of this, is also to, shop around and making sure that you're seeing somebody, whether it's your primary care doctor, your physical therapist, your chiropractor, you're talking to somebody who's trying to get you back to what you're doing rather than just seeing you as another visit, and somebody who's seeing you as just a money bag, so to speak, right? Like
Yeah.
They want you consistently in, so that way we're boosting numbers, boosting revenue, and so on and so
Right.
forth.
And I think that one way for consumers, and meaning patients, the general public, to know if and when you are seeing somebody who is following guidelines and is really invested in you as opposed to their, their bank account, is if you see a provider and they're going to work with you over a period of time as your condition evolves and hopefully improves and progresses, and then they start spacing out treatment and seeing you a little bit less frequently over time, versus the individual who's like, all right, let's get you on the schedule 3 times a week for 4 months. You got to come or else you're going to expire or whatever. I think that that's one way to know, okay, I'm definitely seeing somebody who's invested in me versus somebody who's just kind of doing a cookie cutter approach for every patient that comes in the door.
Yeah, same thing with just like even your money. You don't want to go to like the bank or even just like someone who's going to manage your money and be like, yeah, we're just going to passively just kind of put it in some stocks, see what happens. You're going to be like, no, I want you to like actually like do some research and allocate my money in places that are going to be important, that could be successful, not just like throw darts at a dartboard.
Yeah, that comment is so timely because the meeting that I had just before you was with my financial guy, who was like
Okay.
talking about, I literally have written in front of me, raw goods, emerging markets, stuff I know nothing about, but he was like trying to show me all the charts. And I was like, okay, I believe you because you've got the charts.
Right. He understands what's going on. He's got some data.
Yeah.
And, I think another way to kind of think about this is like how the payment structure for care is interesting. And one of the things that we had mentioned before the podcast was this fee for service model. And I guess let's describe what the fee for service model is. And maybe we can discuss maybe some of the good aspects of it and like the bad aspects of it.
Okay. So the fee for service model is such that, at least in the physical therapy world, there are some codes that are time-based. Most of the PT codes are time-based, and some of them are not time-based. So if you come in for an evaluation, that code is not time-based. So we can take as much time or as little time as we need to perform that initial assessment of what your issue is. And then the treatment codes are largely time-based. So if I'm going to be doing therapeutic exercise or some type of manual therapy with you, each individual code is like 8 to 15 minutes, is like one unit. So the therapist has to spend a certain amount of time in order to justify billing for that unit. And then it goes to your insurance company, and then the insurance company will reimburse the therapist or the provider at the rate that is agreeable for that unit. The positive side of fee for service is you really are just billing for the time that you're with the patient. So if you are seeing the patient, you're doing some sort of treatment with them for 45 minutes, that's 3 units of care, and then you see the patient, and then that's it. The downside to the fee for service model is there are some codes that don't fully capture the education that we provide. The education, like in my opinion, education is part of the therapy experience. You have to be able to educate your patient in order for them to have the best success, especially early on. And then those other, the exercise and the manual therapy is actually less important. It's still very important, but it's less important than that initial education. So that's kind of one of the downsides. Another downside is, in order for private practices to be ultimately profitable or even to break even, the reimbursement rates for each individual fee-for-service code has just been steadily either staying the same as our expenses increase, or the reimbursement has actually been decreasing since the 90s. So you're in a position where all the costs for running a business, turning your lights on, your utilities, your cleaning service, your whatever, are going up exponentially. And what we're getting paid in order to do what we do is flatlining and or decreasing. And there's a huge problem with that, obviously, because if we can't pay ourselves, we can't keep our lights on. And then in order to pay ourselves, what happens is places will often just increase their volume. Not saying it's not right, and ultimately leads to worse quality of care, which ultimately leads to worse outcomes. So it is a huge, like the payment system and the payment model is a humongous issue, but the value-based care is also a big issue, especially for your private, like mom and pop PT places. It might make it so that they can't even stay open. So I don't know. I think that we're seeing such a big shift, especially from a payment perspective. We have identified that there are significant problems, but I don't know that anybody really knows how to solve it.
Yeah, I think there's a lot of people doing, great stuff, but you touch on a couple points. The education piece is so important, right? Like there's research to suggest even learning about pain can affect someone's experience of pain or improve their pain. And so the education we provide is super important. So I think that's a great point to highlight. And again, that's why if you go to some of these bigger clinics that have a lot of volume and you go in there, you see the PT, you get that full hour with them, but then after that, it's like, okay, you saw a PTA, or you're only seeing the PT for like 15 minutes and they're running around doing documentation, or they're
bouncing around with like 3 other patients. I have actually experienced that as a patient, which
right.
is not cool.
Yeah. So, and not, again, some quality of care can be good, and spending time with a patient 15 minutes can be helpful in some ways, because you're building kind of independence, especially if you kind of outline in the right way early on, where saying, hey, like I need to move between patients. But again, it's not that most ideal. It's not, you're not getting that full cooperation and that full attention from that therapist, in which we're kind of getting into this idea of like technician versus like practitioner. And when you go in to see the doctor, you're seeing the doctor. Like that's all of the time that's given is to see the doctor. And if you're only getting like 5 minutes of the therapist or 5 minutes of a doctor, it's like, well, why am I paying you for that service? And I guess
Right.
moving forward, are there ideal models like in place, or at least are there some models that are like coming up that are like starting to kind of shift towards something that's going to help improve this conundrum?
Well, I think that one of the things that a lot of therapists are going to, which I've actually gone to myself, not currently, but in the past, is cash-based practice, which is basically the therapist is not in network with any insurance companies, and the patient agrees to pay a certain amount to receive the therapy, and then the therapist can kind of do what they need to do without having to worry, okay, did I spend 8 minutes here? Did I do blah, 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 like all of the insurance driven requirements. So I think that that's one model of care. But of course, the issue with that is not everybody can afford that. And that was one of my main issues as a cash-based provider is, I don't think that this applies to every case, but I was primarily working with people that were wealthier, or just more well off. And I felt that I wasn't capturing, or I wasn't providing a service that was equitable, because there were patients that I turned away because they did not or could not pay. And I think that so that's one model, that is the cash-based route. And I think there's more, not just physical therapists, but physicians that are providing concierge or like membership services there, because they're trying to bypass this insurance craziness, really. So that's one model. The second model is this concept of value-based care, where the insurance company will agree to pay a flat rate for a specific condition. So like joint replacement is the one that pops out to me because it's one of the most well-established. But like if somebody needs a total knee replacement, the insurance company will agree to pay a flat rate for, your pre-op needs, your surgery, your post-op needs, all comprehensively, including the physician's fees, the therapy that's needed, the assistive devices. And then that really incentivizes the therapist and the providers to get that patient better, to give them they know they're going to get paid that rate no matter what. So it kind of incentivizes them to provide the best care. So I think that that's a potential model, but again, and I won't get into the weeds with this too much, but there's a lot of problems with value-based care too. And so yeah, that's kind of what I want to talk to you as far as like payment models. But one of the things I'm most interested in is researching team-based primary care. and how insurance, this is, I don't even know where to start with as far as payment models for that. But my thought is it would almost be like a bundled primary care option as a part of your insurance plan. And the fee for service stuff just wouldn't apply. So the concept, do you want me to get into the concept of team-based primary care?
Yeah, I was gonna say we can probably start getting into, multidisciplinary care,
Yeah.
and perhaps we can start diving into what exactly it is and how you believe it's a better way to approach care overall, because it's kind of what you saw in the Army, right?
Yeah. So when I was about 3 months out from PT school, basically, I started my career in the Army, and I was active duty and, stationed at Fort Sill, Oklahoma. And I was the first clinic that I went to was a traditional clinic setup. So the therapists each had their own individual office sort of evaluation space. And then there was a big open gym where a lot of like the treatments and PTA appointments would happen. And I spent about 2 months there. And then my boss moved me over to what we call the Soldier Centered Medical Home. And the Soldier Centered Medical Home was comprised of a team of primary care providers, a couple of physicians, a bunch of PAs, I think some NPs as well. And then there was a group of LPNs and medics. So medics are basically like active duty, kind of like active duty MAs, LPNs, depending on like the training is not the same as the civilian sector. But anyway, so support staff and triage individuals. And so I was with these primary care providers. I was the physical therapist, and then we also had a behavioral health professional in our space. And any other services like lab, radiology, pharmacy was very in a close proximity. So when a patient had a neuromusculoskeletal complaint, they could come and see me directly. They could, if they had a couple of complaints, they could go and see their PA or physician. And then if their PA physician was like, okay, they have a cold, they have a blister, I'll take care of those things. And they also have ankle pain. Then they would just kind of send that patient over to my office. And if I had a patient, I would just tell them to wait for a few minutes. Or I would get them on my schedule at some point throughout that day or the following day. So I grew up in this model, and it was awesome because I got to see what the primary care providers were doing and what their training and their skill was. We got to form a really nice partnership with one another. Whenever I saw something that I didn't believe was musculoskeletal, I could literally go right across the hallway and tell their primary care about it. They could address it on the spot. It was I was the most satisfied I've ever been as a provider. And I think probably my peers, my non-PT peers would agree with that for the most part. And same thing for the patients. I mean, I think it's kind of like a one-stop shop for what your needs are. If I had a patient that expressed a behavioral health need, I could walk them right over to the behavioral health counselor and make sure that their needs were met. Instead of like referring them and then hoping the patient follows up on it and all that. So I grew up in this model. And then when I transitioned into the civilian sector, my first job out of the Army was at the University of Oklahoma's Cancer Center. And while PT did have its own clinic, there was this multidisciplinary mindset. So if a patient with breast cancer was newly diagnosed, every week, the breast team would meet and they called them tumor boards. It's a name.
Yeah.
But it was a meeting about all of the new cases that came in with breast cancer that week, what the plan of care was going to be, what their needs were. And it was like the radiation oncologist, the surgeon, the medical oncologist, PT was there. Sometimes SLP was there, depending on like if it was a head or neck cancer, the psychologist. So there was a lot of great multidisciplinary stuff happening there as well. I then transitioned into a kind of a multidisciplinary private practice where it was a sports medicine physician, a family medicine nurse practitioner, and then me as the PT. Great setup, also totally, that was like on a fee for service model, but we still were co-located. So there was really good communication and collaboration between the three of us. Transition into the like sort of traditional corporate PT, not the same. And I was very disappointed by it, just the way that it worked. And that's where I felt that I was in the middle of a regression in our fields, where like they really were relying on referrals, not going direct to consumer exactly, and like, wanting to do everything explicitly as the script stated. And it just didn't work out. So yeah, I think that multidisciplinary primary care, multi-specialty primary care is really the best option for providers, for patients. But because of the whole fee for service model and payment and barriers with that, it is very, very difficult to implement this type of model in the private sector. But I am making it my mission to somehow make it so that we can do that.
Right.
It's
And
going to take me my entire career.
yeah, I think it's gonna take everyone's career, right? We're all gonna have to do a little bit of a part, and I think it's important to know that it is expensive to do, right? And you have a lot of these bigger corporations, like you said, it was the cancer center that did this, and they may have the capital to do so, but mom and pop shop who's trying to do PT in the middle of wherever probably isn't going to be able to hire a nurse practitioner, a primary care doctor, et cetera. So there's a barrier there as well, and I think there's also an important distinction between, when we talk about multidisciplinary care, we're talking about everyone communicating and talking about a patient. So you maybe have a patient and you need to talk to the nurse, you need to talk to the primary care doctor. The providers are talking to one another, which is completely different than like, oh, hey, the pharmacy's across the hall, you should walk over there. Or like the primary care doc is in another building, like I'm going to refer you to them and you can go over there and set up an appointment. And there's still no communication there. They may be really close to one another and it may be look like multidisciplinary care, but there's still no collaboration between the doctors, the nurses, pharmacy, so on and so forth. So just, I think it's important to note like the difference, because I think there's a lot of big companies that are trying to do multidisciplinary care, but they're not exactly doing it the right way, right?
Yeah. So there's a study, and I can give you the reference for show notes, but there's a study that behavioral health providers put together, and it talks about the continuum of integrated care. And on the far left side, you'll see coordinated care. Coordinated care is basically the model that we are all used to. You see your primary care, they refer you somewhere else, and then they just kind of wait to see what happens. The middle of the road is co-located, or sort of co-located, where everybody's kind of in the same space, but they're not necessarily functioning in a model where there's a lot, like after you visit a patient, you talk to the primary care and kind of let them know your thoughts. You still are just kind of doing your job, but you're in close proximity and or co-located. And then there's integrated care. And integrated care is when you have a group of providers that are all seeing the same patient, and then there's a number of different ways that you can do this, whether it's kind of like a weekly rounds base, or just, where we need to talk to one another on a daily basis about our patients, like a huddle or something like that, where every provider, like if the physical therapist sees the patient and the dietitian sees the patient and the primary care provider see the patient, maybe they just have like a quick 3-minute conversation after they all visit with the patient and say, hey, this patient definitely has some needs in this area. And then I identify that as the physical therapist. And then the dietitian says, yeah, we're going to work on this to help get their weight under control. And then I can also assist maybe getting their weight under control with an exercise basis. And then the physician's like, yeah, we really need to get this person's diabetes medications figured out, blah, blah, blah. So that puts the whole picture together. Whereas if just the PT, the dietitian, and the physician were to see this patient and identify like their primary treatment strategies, and they're not necessarily thinking about what else can be done for that patient. That's where I really learned in the Soldier Center Medical Home how to take other body systems and other healthcare providers into consideration. And when that's not done, the communication, it's sparse. It's very difficult. This is like going on another little tangent, but it's sparse and it's very difficult to like find the time of day with other healthcare professionals. We all across the board, whether you're a PT, a physician, a surgeon, a nurse, we all are slammed. Our schedules are completely jam-packed. And oftentimes when I try to call another healthcare provider, I might talk to a receptionist, they'll say they'll call back. I might talk to a nurse, and that's as far as I can get. And so when you experience that over and over and over again, you're much less likely to communicate at all. And I think that's just what happens. People just sort of give up on the whole communication front because it's just too challenging. It takes too much time. We all have our families to get home to at the end of the day. So that co-location and an agreement amongst the providers to have an integrated model is very important.
Yeah, and I don't know if you saw this with your experience, but I guess maybe just playing devil's advocate here. Did you see perhaps maybe unnecessary care done where, you have a patient come in and, maybe they could lose weight, but maybe they don't want to. And, maybe the dietitian this is just an example. The dietitian says, hey, they could maybe lose weight. And the physical therapist thinks so also, but maybe they just don't want to lose weight. Or maybe perhaps, they've had back pain, but it only comes on like at the end of the day while they're working. And so physical therapy is like, hey, like I really want to like help them out, but they're kind of like, I could kind of manage it. And it's only like flares up now and again. Could you see that possibly a negative side effect of it would be like unnecessary care sometimes? Or do you feel like it would be more like, because we're responsible for like referring, that we'd be okay identifying like what's an actual problem and what isn't?
I actually think in the integrated model, it might be reversed because I have seen, and I've read articles and papers about this where physicians or I'll just say medical providers, because that sort of covers the spectrum. Medical providers that are seeing a patient for the first time sometimes overdo because of the issue of like malpractice, like fear of malpractice. I can't remember the study that I just looked at, but like 91%, there was a survey done of a whole bunch of physicians, and 91% said that yes, they have ordered an image because they're concerned about patient satisfaction, or they're concerned about malpractice, or they overdo because of those reasons, not because they don't want to follow guidelines. So I actually think in a model where you have multiple different providers that can actually confirm or deny the need for different tests and measures, or services, treatments, whatever. If you have a group of individuals that are coming together to make that decision or to help assist make that decision, you might actually see that utilization of those things goes down. That's the hope. But I also think it really just depends on the providers that are in the team and what their individual perspectives and training might be.
Right.
So once again, I'm biased, and in a perfect world, I would see that integrated model as a way to reduce healthcare utilization, improve wellness, improve outcomes. And like for that patient that probably needs to lose weight or stop smoking or whatever, and they are just not interested, they're in that, maybe having a behavioral health provider is a really good person to have on that team, because if they're in that pre-contemplation phase, they're not that ultimately becomes the patient is a part of the team. So, you can have the behavioral health therapist provide some strategies that other healthcare providers can use to promote motivational interviewing. So I don't know. I just think that we have so much to learn from each other, and that in a team-based setting, ultimately those things would all be better, I would hope.
Yeah. And I think for the most part, it would certainly be a benefit, because I think a lot of people would be like, oh, I didn't know like you guys provide this option. I can go and talk to somebody who would be, they're right there and them. So that would be great. And it makes it easy, because I think when you start like referring out to other people forget about it, or they have life things going on. So if it's like, oh, it's like, let's do this right now, they're like, oh, okay, let's do it, and I think it's very beneficial.
Yeah, I think that the one barrier to that, or the one exception to that, is, again, we are still functioning on a fee-for-service model. If a therapist or a provider, even in these team-based primary care settings, which are very few and far between in the private sector, but there are some that exist. If the therapist is there and they only are seeing 1, 2, 3 patients a day in that setting, they can't justify their salary doing that. So there has to be some sort of balance between the utilization of all of these services. And I think that is probably the hardest part, figuring out the logistics in the background to make sure that it's optimized from all angles, that the providers are seeing enough patients to justify their salary or their, compensation, and that the patient is receiving adequate services and that they're accessible, and affordable and available. It is, like I said, it's going to take me my entire career. It's going to take dozens, maybe hundreds and thousands of other people their entire career to try to figure out a better way to do this.
Yeah, and I'm going to put my tinfoil hat on here for a second. And I'm thinking, why doesn't basically the insurance companies have every right to not go to a more efficient program, right? Because if they're providing better care, that means maybe they're not coming in as often, and maybe that means that they're not going to get paid as much. And I guess, do you think that maybe the hesitancy towards insurance companies to try to adopt a new or more efficient program is because, like, well, now we're not going to get paid as much money? And again, this is just complete speculation. This isn't like but perhaps there is a part where they're like, okay, if people are not sick and people are getting better, why aren't we going to get paid?
Okay, so I actually think that in a world where there are people that are less ill or less injured, or where we are functioning on a truly preventive scale, that the only people or group of individuals that are going to lose out are the healthcare providers and the health systems.
Mm-hmm.
Because ultimately, if people are coming in for less care, that means the insurance company is going to make more money. Same thing with employers. So employers and insurance companies, typically people get their insurance through employers. Employers save money when their employees go to the doctor less. So insurance companies would be pumped if we had better outcomes. But the issue with this is, then how does the healthcare provider ultimately get paid if preventive services and other types of wellness services are not offered or not covered under the insurance plan? Nobody makes money that way. Or I'm sorry, the health system and the healthcare community, healthcare providers, nurses, doctors, physical therapists, we don't make money if our patients are ultimately well, because nobody covers wellness services. Whereas a physical therapist is in a very unique position to provide something like an annual neuromusculoskeletal screen. So some people go to their primary care physician once a year for an annual well check. Insurance covers it. It's usually free to the patient, because we want to, the insurance company wants you to go for your well visit so that they can prevent you from having disease so that you cost them less money. But those visits typically give the provider the lowest reimbursement. So there has to be a way where employers, insurance companies, and healthcare providers can all live in some sort of symbiosis, and especially patients, because that's ultimately what matters at the end of the day, is if you're altruistic and not money driven, which again, I'm like questioning if that really truly exists these days.
Right.
But these three parties have to exist in some sort of symbiosis in order to make it beneficial to all, because the party at the end of the day that is suffering from this is the healthcare providers. That's why so many physicians, so many PTs, so many dietitians, so many psychologists are just going cash-based. They're not even in network with insurance. But then again, that limits the patient's accessibility to that care. So I don't know how this is going to be solved, but I think that it's important for the general public to be aware that this is a problem.
Yeah. And we're kind of,
go ahead.
I was going to say we're bashing some of the bigger corporations, and I think they need to kind of adopt the multidisciplinary care. But also, how important is it the general public understand what we're talking about? Because I know, some people can kind of, their eyes can glaze over when we start talking about this stuff, but the stuff is so important in regards to just how much you're paying, like the quality of care and so forth. And I guess, should we take an approach of, yes, insurance companies, healthcare providers, everybody's got to be working together to try and figure this out, but also in the sense of, I think the education and, so to speak, with the general public of like how to take care of themselves, or at least how to stay healthy, is also kind of lacking. So I guess, is it the chicken or the egg kind of thing? Should we be focusing more on educating the public of like prophylactic care? Or should we also be just, expect these healthcare systems to get their act together? Or
And for
both?
people who are just listening, I'm like I'm shaking my head a little bit here because I don't know the answer to that question. I don't know the answer to that question. I think that our population in general could use more help and assistance in wellness behaviors from a very early age. And that's something my sons are 3 and 5, and that's something that my husband and I are really already implementing in their life. Is it is important. It's not good for your body to have a lot of sugar. It's not, you need to exercise. It's important and healthy to exercise, leading by example. Having school systems make sure that their health education programs are as robust as they possibly can be. So I think that kind of stuff is really important from like a population wellness perspective. But as far as, can you rephrase the question one more time? Because my thoughts just went away from me.
No, it's okay. It's the chicken or the egg in regards to, do you think that the system should be more responsible for quality of care? Or do you think the individual, so to speak, so like you and me and everybody else, should be educated more on how to take care of themselves better? Like better, should it be coming at an education level? Should we really, I mean, obviously the answer is both, but at the same time, do you think we'd see greater changes if we focused on trying to educate the public on like how to take care of themselves? Or do you think it would be more time efficient, just like try to get the policy in there and try to make healthcare systems work together to try and create a more efficient model for people?
I really think that this is don't call me a socialist, because I am not a socialist, but I think that it is kind of everybody's responsibility.
Mm-hmm.
It's the responsibility of the health system. It's the responsibility of the individual healthcare providers, the insurance company, because we're not talking about car insurance here. Like these are people's like human lives.
Mm-hmm.
And I think that they need to do their job and being altruistic in that way. But also I think money talks. And I might have explained this to you or someone else yesterday, but I just had a conversation with somebody about, my husband used to work for a company that they would actually give him cash payouts for completing a certain number of health related goals or tasks for the year. And one of them, or just to name a few, getting an annual wellness exam. So going to your primary care doctor and having an annual wellness exam, getting blood work done, checking into the gym at the facility a certain number of times per year or per month, getting an ergonomic assessment of your workspace. And the list went on. There was like probably hundreds of items that people could sort of complete. And then they would get cash payouts to their HSA accounts. So that's just more pre-tax money for the patient. And my husband, he's a very healthy guy. Like he works out a lot, but he really doesn't care about like his personal health beyond like not gaining too much weight. But he did all these items because he was like, yeah, I get a lot more money for doing that. And guess what? The employer ultimately saves money by doing that.
Mm-hmm.
So I think that incentive structures via employers, that's one really great way to speak to people. But then there's also, I mean, that was a major Fortune 500 company. Not a lot of employers can afford to do stuff like that.
Mm-hmm.
So I don't know. I kind of want to research like what the Nordic countries are doing and how it is there, because we know that in the Nordic countries, typically there is lower rates of obesity. People are healthier, lower rates of cancer and heart disease. And I kind of want to study that a little bit more, but I don't know, America's like its own little
Pocket.
right. And we just are who we are, and we do what we do, and we love our freedoms. And yeah, so again, that's just a really hard question to answer, but that's where I would
Yeah.
start, like incentive structures.
Right. And I think, like we said before, I think it's both. We need to focus on the side of things where we need to be educating the public as much as possible. And we said this before, where we need to be paid for that, because even just being educated on pain can help affect your pain and how much pain you're in. And so I think I like that you got into the idea of also talking into, some of these work related things and how money talks, because sometimes the only way people can get involved with their health is like, hey, this is free, or like, hey, you're going to get money to do this. And they're like, oh, well, let's do it then, and that's the only way people are going to get involved, unfortunately. And maybe that'll change. And perhaps with education that could change. But again, tough conversations. But overall, I think I want to continue talking on the side of like education. And I guess, what are physical therapy programs, or maybe other, like maybe medical school or other institutions, doing to try and teach people how to be multidisciplinary and try to work in a collaborative practice? Is this something that's being implemented regularly? Is this something that's just new? I guess, speak to that.
I will say, when I was in PT school, we had one day where we were all, as this was like, very first couple of weeks in PT school, we were assigned a different health profession. And, our group had to come up with like, what does that health professional do? And then we would all present on it. So I remember our team was speech therapy. And that was something that was easy for me because my sister's a speech therapist. But yeah, we sort of learned that way, but that was it. Like all of PT school, we didn't really do anything with any of the other health professions, even though we were on a medical campus. The medical school was right across the street. The dental school was right across the street. Like everybody health related was there. Pharmacy, I can't even, OT was right down the hallway. We didn't do anything with them.
Mhm.
But now I know that there is more of a push for, at least for DPT, but I think for other health professionals, to start doing these interprofessional service days. So they'll have like one day where each health professional student, or each student program, would come together and do some sort of activity together to increase interdisciplinary collaboration, or at least set the stage for it. I would love to see education programs provide courses, like everybody needs to learn how to do a basic orthopedic assessment across the board. It's going to be maybe just marginally different or marginally more intensive or less intensive, depending on your specialty. But every PA, every physician, every physical therapist, OT, chiropractor, we all need to learn how to do a basic assessment. Why not just take these programs, put them all in the same class so they can start talking to each other? And then that effect, hopefully, would carry over into the profession. They might see, hey, a physical therapist might be really good at doing this, or a PA might be really, really good at doing this. And it would just set the stage for more interdisciplinary collaboration once these students get into the field. That's the hope, at least. I think it's trending in the right direction, but it's like it kind of you start with all of these great, the ideal situation when you're in school, and then when you get out and start practicing, and then you see that or you get in your clinicals and nobody is talking to each other. That's just kind of the model you end up falling into. So something has got to change.
Well, it's funny because it's the same thing. Like everyone's like really close to each other, but they're in different buildings or they're down the hall, and still like
Right.
no one's talking to each other as much. And it's like, well, that's also how the healthcare system is. So it's just ironic how even from the beginning, and when you start learning about this, it's, we emphasize multidisciplinary care, but do we practice it? And it's like, well, we can say it, but are we doing it? And I think that's important. And I guess, where are new grads lacking information to help combat some of these issues? Is it lack of skills? Is it lack of referral knowledge? Do you think it's just overall confidence to try and get people to refer out? I guess, what are your thoughts?
I think in school you spend so much time just learning your skill and learning what you do, but you don't learn how to communicate you don't learn how to communicate with other health professionals per se. You might, depending on the program that you're in, but you probably don't, and you don't have the practice doing it. I remember one clinical rotation that I had. I felt this patient he needed imaging. I just felt it was an acute care setting, and it was a patient that they had sort of like cleared for hip pain. But like every time I moved his hip, he had this very sharp searing pain, and he had a fall. And I was like, but he had a negative x-ray. And I was like, but a negative x-ray doesn't mean he doesn't have a fracture. So ultimately my CI, or the example that was set for me at that time, was, but the doctor looked at him, he had a negative x-ray. And then there was no communication beyond that. And it was me pushing and pressing to get this patient more imaging, because I felt that he needed it. And that patient ultimately had a spiral fracture that was missed on a radiograph.
Wow.
And then they caught with a CT. And so the example that was set for me was, well, the doctor already cleared it per notes. So, like looking back in the chart, not actually talking to anybody. And, if that's quote ruled out, then we don't need to do anything else. It's not our job.
Yeah.
So that is kind of that's what I'm talking about. Like, we have all the ideals maybe in school, but the model or the example that's set for us when we get out into clinic is not as progressive as I think it really should be, especially with interprofessional collaboration. Like, I remember this other therapist that I've just seen over time is just like hated getting on the phone with people. She was always like nervous and like concerned about what the outcome was going to be. And it's really like, you're just explaining what's going on with the patient.
Right.
You just
like,
need their opinion. It's just a conversation. So I don't know. I don't know what the issue with that is.
Yeah, I had a similar story. I was in a nursing home, and we had one patient who had already gone through a joint replacement, and they were on their second one, and they had been prone to infection. And so it was their second joint replacement, and she had been doing great up until recently. And the nursing staff had noted that she had trouble sleeping, and she's agitated because like the out of bed staff would like let PT know how they're doing. I would try to talk to the nursing staff to see like how are they doing today, so on and so forth. And so like all day nothing happened for this patient. And I don't think the doctors got into her that day. I think they just were too busy to go into that section of the wing. And so I saw her later in the day. It was like maybe like 2 or 3. And she came onto one of like the plinths to see how her knee is doing, just like to take a general measurement. How we doing? And I removed where the bedding is, and her leg is like red, and her skin tone was kind of like already like kind of red and white. And so it was difficult to kind of say, but like her leg was very warm. She was complaining of so much pain. And I was just like, there's something going on here. Like, this is not, and I'm a student at this point. So like I had a CI and everything. And, I was kind of working with her independently, but I was like, I know this isn't right. And, I don't want to miss this, especially if something's wrong. So I remember I had ran down the hall because a doctor had recently walked by the place. And I was like, Doc, do you see this person? And I was like, you need to like see them to make sure they're doing okay. So they came into the clinic and saw her, and she's like, yeah, let's get her in for imaging. And she ended up having a DVT. And so just getting her, like, who knows if she like would have went, like, if I didn't catch that and like she went back to her room and like fell asleep that night, and never know what could have happened. But her whole leg was red and everything. And thankfully I had the confidence to be like, I'm gonna go talk to the doctor. But I can imagine other students being in that scenario being like, I don't know what I'm talking about. I'm just gonna like throw it under the rug and not saying anything. And I think we need to have the confidence to be like, what we're talking about, and even at least identify like this isn't right.
Or especially as students coming into clinical settings like that, like I was a student in the scenario I explained as well. We need to have the example set for us that interdisciplinary collaboration and communication is something that takes place on a daily basis, or at least a weekly basis, no matter what. No matter what, that we are on the phone, or we are, chatting across the hall or whatever, all the time. Because when that doesn't happen is when stuff starts to break down, and the only person who ends up suffering is the patient.
Yep.
And that's not acceptable. It's not ever acceptable.
Not at all. And was this, we've been talking so much about, the changes in healthcare and changes in education. And I guess, was this you also have a company and it focuses on continuing education, and I don't want to miss this. And so, why don't you explain to people what your business and your company is all about, and what you're doing to make leaps and strides towards educating people on continuing education and so forth.
So I started Redefine Health Education like a lot of people did in the beginning of the pandemic, because my cash-based practice was pretty much shut down for a while, and I knew I wanted to get into the education space anyway. So Redefine Health Education, one of my primary goals and missions is to promote this concept of multidisciplinary, interdisciplinary practice and education. And I'm hoping to do that by providing education opportunities for physical therapists, but also other healthcare professionals or health systems that are interested in implementing the team-based primary care model. This is something that I hold very near and dear to my heart. It is very, I've had the best experience in healthcare working in a team like that. And I think that healthcare outcomes and patient experience is ultimately optimized in that setting. So my company is really focused on providing not only like skill set education, so foundational knowledge in medical differential diagnosis and practicing the model of care and interdisciplinary collaboration and communication, but also how to educate administrators and business professionals on how this model actually can work, the logistics behind it, the setup, the payment plans, and then hoping to maybe drive research in that area, because we just don't have enough on it. The models are very inconsistent from one health system to another. So we also have, I think that imaging and PT primary care practice really go hand in hand. So I've partnered with Dr. Lance Mabry, and he is the Redefine Health Education Imaging Coordinator, and he was on one of your episodes recently. And I think together we're creating a really great product for PTs to enhance their competencies in this area so they can truly practice as first contact providers. I also want to mention that I have a great team that helped me develop this primary care content that I'm working on. Doctors Mike Ross, Julie Skurzat, Jason Srolia, and Lance Mabry was also on that team as well.
Yeah,
and also looking at incorporating Dr. Josh Prale to help with occupational health as it relates to primary care.
Yeah, Josh is great. I talked to him as well. He's
cool.
Yeah, he's great and very, very loves what he does, and it definitely shines through when you talk to him.
Definitely.
Yeah, and overall, I think what are you most excited about next? I guess what are the next plans for Redefine Health? And you said dabbling in research. Are you planning on doing any research anytime soon? I guess what's the future for you and your company?
The future for the next year really is just finding where people, facilities are already doing some form of PT and primary care, figuring out what their model is, what the barriers are, what the successes are, and then trying to put that all together somehow into a picture to create like, what is the ideal setup for what this looks like? And then from that point on, I'm hoping to work with various researchers to put some stuff to the test, see if it actually is better and is more cost effective compared to the traditional care. And if we can demonstrate that team-based primary care ultimately improves outcomes and saves insurance companies money, guess what? They're probably going to start paying for it. And maybe that will drive some sort of change in the payment system. Maybe they'll do some sort of bundled primary care payment as opposed to like bundled joint replacement. So I don't know. These are all just ideas in my visionary brain.
Mm-hmm.
But if nobody takes the lead on this, we're just going to end up with like a sicker population with worse and worse outcomes. So I'm just going to try to do my best to create a positive change in this environment of healthcare that I think is so jacked up.
Yeah, I mean, there's, we could talk all day about the different, like the issues with healthcare, but I think, starting in your own profession and doing what you can at the very least can at least start pushing direction and steering the ship towards the way that we're supposed to go.
Yep, for sure.
Well, believe it or not, we're almost already at an hour. So I want to thank you so much for coming on the podcast. And I'm going to finish off the podcast with some closing remarks. And so these questions are questions I ask everybody. And so the first question is, if you had the attention of everyone in the world for 30 seconds, what would you say? And I know it's a daunting question, but and maybe give you a couple seconds to think about it, but it could be pertaining to your career, things you learned, or perhaps, we talked about a lot today with education for, PT programs and everything. So I guess if everyone in the world's like, Katie, what do you got to say for 30 seconds? What would you say?
I would say for everyone in general to take charge of your health, take charge of each component of your health, from physical, medical, mental, emotional, spiritual. Take charge of your health in some way, where you can help, manage your stress, improve your physical fitness, improve your, your gut health, your mental health. I mean, I think over the years, I am the kind of person who has struggled greatly in a variety of areas, physically, mentally, emotionally. Like I've definitely had a lot of struggles, and I spend a lot of time taking care of myself. And if people would start to do that and start to identify like when they're having a problem and receive help for it, adequate guideline concordant help, then we really would have a much better health overall and better society overall. So that's my charge. Take charge of your health.
I love it. It's a great message. And I guess, how can more people learn more about you and find more about your company? I'll include everything in the show notes, but if people are just listening right now, where can people find out
Sure.
about you?
Sure. So obviously my website, redefinehealthed.com. You can email me at info@redefinehealthed.com. You can call or text me at my company number 312-772-2322. And we're on all the social medias at Redefine Health Ed. With the exception of Twitter, we're at Redefine Con Ed because we were one character too long. So
Twitter's always got those restrictions on things. I don't
so
understand.
annoying.
It's so annoying. Well, listen, Katie, thank you so much for being on the podcast today. I really appreciate it. I'm sure everyone's going to learn a lot.
Awesome. Thank you so much for having me. I really appreciate it.
Of course.